Good evening, everybody. I'd like to share my personal experience of using the wide field imaging systems at RPC, and I hope it finds some use to us in this 1.5, 2 hours to discuss our experiences and share it with the various people, ophthalmologists in this country who would like to get interested in this imaging modality. And also, we want to just tell you a few tips which we have seen ourselves. So wide field imaging is actually very useful, I feel, because for me, I feel, as personally speaking, I often get it done because you have to see the periphery of the retina. I have no financial interest in this presentation, which I would like to make clear in the beginning. Why is wide field imaging useful? Because the periphery of the retina is involved in a whole lot of retinal vascular disorders, uveitis, vasculitis. So you will retinal inflammations, the vein occlusions, especially and also diabetic retinopathy and retinal detachments, tumors. And it also pretty mature, of course. ROP, we have got a learned speaker with pioneering work by Dr. Spadar Jalali and all the others. So she'll be talking about that. So I'm not talking at all about the red cap. But it's changed the way we look at the fundus and we understand the fundus much better. And with conventional, we normally get about a 50-degree field as you do before with the, you used to have the Zeiss system, can have the Topcon system. So various systems are there, but what happens is the dye exits or you can't capture the image in the periphery, even if you take a montage. And it's actually, you don't probably don't see changes which are there in the periphery in the beginning of the angiogram. So you don't get a single shot, single capture image of the periphery at one go. So here you get about 200 degree. And so what you can see is here very quickly, I'll tell you that it's about 30 to 50 degree image. The ETDR has told us in the 80s that you got to take the 7 standard field, SSF, which was actually coming from 30 degrees, 7 fields, to come to about 90 degrees field. So what we never visualized was the periphery. So grading system was based entirely on the posterior pole. And here you got a 200 degree field with a single capture. So it's made a awful lot of difference. And this is the ETDR standard 7 fields, which gives you about a 90 degree field. And you can see a 200 degree field. It's all the go to the periphery and nearly about 82% of the retina is imaged. So this is just to tell you the posterior pole is 24 to 24 millimeters as per the new definition of the International Terminology Classification. And where a group of retina specialists got together, and including the Giovanni Storengi and all that, leaders who are pioneers in the field of retinal imaging, the various lenses they've made and everything. The posterior pole is actually 50 degrees, and this 50 degrees is covered in the 20 to 24 into 24. So mid periphery goes up to about 100 degrees, and which is actually called the wide field imaging. So the definition of wide field goes up to the anterior limit of the vortex veins, and it's called wide field. You can get that in probably the Heidelberg imaging systems. It gives you about 102 degree field. So it goes into ultra wide field. So beyond 100 degrees is what you call as ultra wide field, which goes all the way to the periphery, not totally to the periphery, but about 200 degree field. And pan-retinal, of course, is 360 degrees. You often use it for imaging, but probably you don't have any gadget for that. But we, of course, use it for surgery. So the more important ones, which are the commonly used ones, are the have been listed here. You can see it on the screen. The Heidelberg Wide Field Imaging Module, which is a confocal SLO system, which offers you with the lenses, it's a 30 degrees inbuilt lens, and you've got a 55 degree, 68 degree, or a 102 degree. The 102 goes into the wide field, ultra wide field beyond 100 degrees. The Giovanni Storengi introduced the 150 degree field, but you got to attach it to you got to use the contact procedure. These are all non-contact wide field imaging. So everybody prefers a non-contact wide field. Of course, for the red cam, for neonates, you need the wide field. So it gives you 150 degrees with the Storengi, but we rarely use this. Personally, I've never used this, so I have no experience of using the 150 degrees field. So I use the 102 degrees field for lesions, or whenever I like to see the periphery, which I listed the various. The red cam of the Forest Neo actually gives you the contact wide field for neonatal pediatric eyes, 130. The Optos 200 degree TX or the California or the Silverstone versions are the non-contact images, both. I'm sorry, the autofluorescent imaging, the fundus pictures, the ICG, the fluorescein angiography. So it's wonderful. And like every OPD, I've got to use it. I mean, it's no way I can't use it. I mean, it's a must. So many of the pictures, I don't go for every patient for 200 degree. When an AMD patient, I don't need it. So various other cases also. But for many patients, where even for a serial follow-up, to see the effect of the laser, the periphery, or a diabetic PDR patient or a patient will have lasered, I like to have a view, not every month, maybe every 3 months. So even you can steer the patient's eye and see the periphery. So this is the confocal SL. They are both confocal SLO systems. The Optos, uh, this is the California version which we use at RP Center. And my personal experiences with the confocal SLO system used by this California version. And this is the Heidelberg system, which is also confocal SLO, goes up to 102 degrees. And this has a unique ellipsoid mirror, so you get a flat image. It's like the world map seen flat. So you don't actually, the line drawn in the center is not equal to the line drawn in the periphery, but it gives us a whole lot of image information. So this is the new Silverstone, which we've understand, and we probably will like to be going in for a live demo soon, very soon, from Optos people. So you can see peripheral lesions can be picked up. When you're not sure of the lesions, you can probably do the OCT and see microcystoid degeneration, small tiny breaks, which probably are missed. So this is a classical case which I just saw about in the COVID period, and all these are fresh images which I've taken. So you can see that this is the patient on the Optos. You can see zoomed up. So you got a lot of, I've just marked this. The zoom is 2.84. You got these tools which can sharpen your image, improve the color contrast, enhance the image, zoom up the image. So all these are excellent additions. These are my personal experience. I'm not talking because I'm in this session. So my personal experience is that I can see the lesions very clearly and see the vascular component, the amount of avascular areas which are there very well, even better than any 30 to 50 degree system. So this is another patient which we saw in the pre-COVID era, which came to us. Often patients come because they never advised a fundus examination. So not only is the fundus examination important, but if you have the wide field imaging systems, you can also go to the periphery and see the entire CFAN like neovascularization, which is in the case of a neglected diabetic retinopathy patient. The swept source OCT showed us the retina was totally detached. These kind of end-stage PDR patients usually don't benefit from surgery. This is another patient where, like I said, the serial pictures, this is the initial picture with a lot of neovascularization, but you can see, if you had done the 7 standard fields, you probably missed out all this non-perfusion areas, and the non-perfusion areas are extensive. So what you have to do is you've got to target your laser onto these peripheral non-perfusion areas and probably close these neovascularization, and don't put laser in the center, which may be more harmful for the vision as well as the dark adaptation. So this is the other patient. I just want to show you that it's actually a patient who's got a 15 years history of DM. He had PDR done already, but when we did the wide field imaging on the Optos, California, we saw there was a retinal detachment coming on, not involving the fovea, but threatening the fovea. And you see the amount of laser which has been done, probably because of the hemorrhage, this laser has not been completed in the inferior quadrant. So what you have to try is that you can augment the laser with the Pascal, as we do. We have I like to use the Pascal laser because in PDR patients, I like to give multiple spots in an array of 9-spot pattern or whatever. It's been reported and well documented that, which I'm showing in this particular slide, that the ultra wide field angiography actually picks up more retinal area. It shows more areas of non-perfusion early phase, and probably also the more areas of neovascularization. And this is all documented in the article which was published in Retina in 2012. This is well known. So this is a patient with a montage has been taken on a standard 50-degree fundus camera with the fluorescein angiography done. He had diabetes with very poor control vision of 660. So this is what we saw on the montage. We zoomed it up on the ultra wide field and picked up late phase angiogram. You can see the dyes exited. You can see the amount of neovascularization which are actually very highly visualized, very well visualized, and the non-perfusion areas where you like to. So now there is the era of not only doing a pan-retinal photocoagulation or full scatter, you do a targeted laser to prevent problems of side effects of laser. This is another patient of branch vein occlusion supratemporal, which you see the arrows show that what we had seen here is actually only mid peripheral. If you see the vessel crossing here is the same vessel crossing here. This is the end of the zoom of the montage. But way beyond it in the periphery, you can see the extent of non-perfusion. We probably may or may not have treated this patient if he depended on a standard 50-degree camera. So you see the amount of laser he requires is extensive to prevent any neovascularization subsequently. And this is a case of fungal after endophthalmitis. We often take fundus pictures of patients where we like to also document patients and also know the extent of involvement of the uveitis, vitritis, or endophthalmitis wherever it's possible. This is a patient who came to us with retinal detachment with severe PVR and a fixed fold very close to the disc. The macula is off, it's totally detached. So, of course, surgery can be planned, but if you do is optos, wide field imaging fundus for optomap picture, you see the peripheral toxocara granuloma, which is the inflammatory granuloma. So, you'll have to tackle this. I'll have to tackle this, which I did. Of course, there was a traction over here. So, I'll have to relieve this traction as far as I can or create a U-shaped retinal, relaxing retinotomy. This is another case who came to us with a self-settled retina and some exudation. So if you do the fluorescein angiography, actually, you can see the classical Coates disease. And the Coates disease shows you extensive areas of telangiectasia, very self-explanatory with non-perfusion. So you know exactly where to treat. So we get often cases of Coates. I always like to do the fluorescein. And all these cases of retinal detachment, especially giant tears and all, of course, indirect ophthalmoscopy is an excellent method of viewing. It's a subjective method of viewing. But you want to document the entire area of giant retinal dialysis or a tear. And afterwards, when you put in oil and done the vitectomy and everything, the laser marks. So you can see the extent of detachment. You can follow up this patient on indirect. At times, you can do the photographic examination. So this is a patient of radiation retinopathy, maxillary sinus tumor who had come to me and in the last 3 months, I think, 3 months back. So we could see the extent of neovascularization on the nasal side. So often we take the pictures are on the macula and disc. So probably the nasal side is also very important to see with all the fundus patients. And we saw all these changes and we treated the patient. So coloboma is so common and we see so many patients of this, and I like to do sometimes like to just take a documentation, and I knew the retinal periphery is well attached because often these patients may be young and not fully cooperative. And this is a patient, the Heidelberg imaging 102 degrees, which I told you also goes into in ultra wide field imaging. This is a post branch vein occlusion, actually inferotemporal. This is C-fan-like neovascularization, but what is important to see is we have to treat this, and this treatment is very important in the periphery. So this is a patient who had a history of carcinoma, CA breast, and the old lady who had come to us, and she had choroidal metastasis. So which was picked up on the OCT. You can see the irregular mass under the choroid. But if you do the 102 degrees ICG, you actually see the lesions going all the way to the periphery. So this is one disease which I like to highlight, that I've seen a lot of fever cases, and I would just like to say that the diagnosis which could be missed. I've done a lot of surgeries in these eyes also. This is a disease which may be having a lifelong follow-up, and you have to laser well. I have cases who've lost one eye, but they have the other eye staying okay because we've lasered well. And sometimes the ischemic areas also extend to the nasal side, as I've seen in some. So you've got to do a wide field imaging. There is no way out for a fever patient to get a standard photographic examination. Fever cases require peripheral fluorescein angiography. This is one absolute probably indication I feel where the wide field imaging has a major role. This is a patient which I had operated of a 17-year-old male patient of a fever patient. He had a combined RD. Often we see RDs, retinoschisis also I saw once with a fever diagnosis. So peripheral, you can see the new vessels on the wide field imaging, the Optos, California. And this was after the surgery. So of course we lasered the periphery and we settled the retina. I put a lot of laser over here, extensive laser. These white marks you see, I put sometimes intravitreal transfer. So the fever is, you can see the peripheral ischemic areas and the neovascularization. It's just go on ahead. So this is another. Now I'm coming to the vasculitis patients, and you can see, the periphery we have new vessels, probably in a patient of Eales disease, and Eales is not so uncommon in our country even now. And with the advent of COVID, we'll probably see more because we're seeing patients with all kind of vasculitis and diabetic retinopathy progressing, and India is going through a rough phase like the rest of the world. The US president is also involved now. So we're seeing a lot of advanced cases of various vascular pathologies, and you can see that these vasculitis patients also, you don't treat the new vessels only. You got to treat the periphery. Only then will these new vessels settle. So this is a disease which is, we well known polypoidal choroidal vasculopathy, but the periphery you can have PHCR, which is actually peripheral exudative hemorrhagic choroidal retinopathy, and comes up with a mound. You have a faculty member in the AIMS whose mother has suffered from this. So she comes up and gets her optos fundus picture and sometimes the fluorescein. So we have to treat these patients, the anti-VEGF and laser, and they do very well. They become stationary. This is a case of retinocytoma. There was a kind of a choroidal coloboma here with retinocytoma lesions. You can see there's a choroidal, there's a cavitation, choroidal cavitation, and this is probably the coloboma a little bit, and the astrocytoma over here. So we just did the octa also. So it's a multimodal imaging, but the wide field really helps. This is just to show you that the ICG imaging comes up very clearly, and you can zoom up and see the periphery. And towards the end, I just like to tell you that it's a case of suspected rickettsial retinitis, occlusive vasculitis. So you'll see the peripheral vasculitis. So we wait for the infection to settle, and often they don't do so badly. And you probably just need a little bit of laser if at all. So this is another case on this is doxis. The same patient was put on. You can see the multiple exudative, the white exudates, like a soft exudates all over, rickettsial lesion, and this patient did very well on doxycycline, oral steroids. So we probably just follow up this. If at all some new vessels develop, we'll treat, otherwise we may not. And this is a case of CMV retinitis, very extensive, with the retinal all pulled up, and so you can actually image it and see the extent of the CMV retinitis, which is healed, but it's caused extensive fibrosis and retinal detachment. And this is a case of retinal vasculitis with classical sarcoid, a candleback stripping. So beautiful imaging in the periphery is visible, and you can treat and serial follow up, and you can your treatment can be altered, and you can treat based on the wide field imaging. This is a patient of HIV retinitis. You can see the extreme degree of necrotic retina and the amount of involvement. So the extent of involvement is very well picked up on a single click. And of course, I just wanted to end my lecture saying that wide field systems are not only for imaging preoperatively, but also intraoperatively. We all use the non-contact or contact wide field imaging system. I'm also very fond of it because without this, I can't do anything. So wide field is here for even, this is a contact wide field of a patient who had a giant retinal tear. So the end-to-end, I like to see the retina panoramic viewing. If you don't get panoramic viewing of the retina, with the Optos or with the ultra-wide field imaging system or during surgery, you don't know what you're going to do in a particular portion of the retina. The rest of the retina may actually be having a lot of problems which you miss. So you have to use systems which see the entire 360 degrees of the retina. So it's very important is just putting carbon in and unroll the flap. So this is just before I end. So it has some drawbacks, but I think the advantages far outweigh the drawbacks. And this is a Mercator projection which we get. It's like seeing the world map, the green field effect. So sometimes you get the lashes come into field, a pseudocular image, but pseudocular image hardly makes a difference. So even for telemedicine, you can take a single picture and transport it. So we got a future of telemedicine with the COVID era coming in. So you just take a picture, and in non-ophthalmologist areas, these pictures can be sent to a main tertiary center. And probably it can be very useful, a big picture image if you get. So I think it's not to get standard of care, but it's coming in evolving very fast. Thank you very much.
Thank you so much, sir, for that very comprehensive and illustrative presentation. There are a few questions, I think, which were answered even in your presentation. So there was one question whether it is convenient to diagnose all types of retinal diseases, and whether there are any diseases which there would be limitation of in diagnosis.